Okay. Let's start, shall we? I'm not Dr. Hallberg, as you can see. He's gone. And today, I'll make the introduction. We will have you fill out your evaluation sheets, please. Dr. Imborek will tell you how she would like any questions, when, and so forth. And so today we have with us Catherine Imborek, better known as Katie, who is from Indiana originally, went to DePaul University, University of Iowa for medical school, and then has been at Iowa ever since, having a family medicine residency at the University of Iowa, and then has been busy around that area of the state in various things, including clinical assistant professor in the Department of Family Medicine, medical director of UI Healthcare of Southeast Iowa City, co-director of the UI Lesbian, Gay, Bisexual, Transgender, Queer, and Questioning Clinic, family medicine primary care lead for University of Iowa's eHealth and eInnovation Centers Project Core. She may want to tell you about that. Telehealth, and also director of the off-site primary care for the University of Iowa Healthcare at Iowa City. So please welcome Catherine Katie Imborek.
Thank you so much, Louie, and thanks everyone for inviting me and for having me. So just before we get started, do I have until 1:10? Is that correct? Okay, very good. So my hope is that we'll do my lecture until about 1, and then maybe leave some time for questions afterwards, if that works for everyone. So what I was asked to talk about today was caring for the transgender patient, specifically really talking about primary care types of things. So just so I can get a little bit of a pulse on the audience, who in the audience is a physician? Great. All the physicians are in the back of the room. I'm not going to make any judgments about what that does or doesn't mean. And then do we have any APPs in the audience? So nurse practitioners, PAs? Couple of those, wonderful. And then any nursing staff? Lots of nursing staff. Social workers? Couple of those. Pharmacists? Couple of those as well. And then do we have any student learners here today? 2 student learners, very enthusiastic as well, raising their hands. Welcome, thank you. And then just another kind of quick pulse. Whatever specialty or whatever sort of rank that you may have, who's in primary care? Who works in that field? Okay. And then we have the rest of you, specialty care? Yep. Okay. Wonderful. So just a little bit about our clinic at the University of Iowa. So this is myself with Dr. Nicole Knisely. So Dr. Knisely is a general internal medicine doc, and I just wanted to spend a couple of minutes and talk some about sort of how our clinic was started. So this was right after I had graduated from residency in 2011, and I was getting ready to join faculty at the University of Iowa in one of our off-site clinics, so kind of away from the big main campus. We have a number of family medicine clinics within or near Johnson County. And I was thinking about our intake forms. You know, I'm starting at this new practice, and I'm thinking like, wow, I mean, I get to look at our intake form and potentially throw it out the window and change it or suggest that we add some things to it. And so I was specifically thinking about how to make it more inclusive for LGBTQ folks, specifically transgender patients, because I had a couple of those as a resident, and I was interested in it. And so in Iowa City, a group called Trans Collaborations, which was really kind of focused on the University of Iowa students, but also invited some folks from the surrounding community. They, in celebration of Trans Health Week, had a panel of transgender identified people that were talking about their experiences in healthcare. And so I went to this panel in the evening time because I felt like it was pretty applicable to what I was about to start doing. And Dr. Knisely was also there. And we had just probably known of each other, mainly because she lectured to me when I was a medical student. And we were sitting on opposite sides of the room, and when it got to the question and answer period, we both stood up and asked some questions kind of pertinent to our practices. And then I came to find out that Dr. Knisely had one patient in her practice who identified as a transgender woman, and she felt pretty ill-equipped to care for that woman. And she thought, you know what, I can't believe this. Like, I can't believe that I got through medical school and resident, and I've been a faculty for a long time, and yet I saw this patient, and I just felt like I didn't really know as much as I needed to. And that's the kind of person that Nicole Knisley is. So she took time out of her family life, and in an evening, and she went to this panel to learn because of this one patient that she has. And so afterwards, she came up to me, and she said, you know, do you know what? They're going to have us do an evening clinic once a week. We have to work from 5 to 8 p.m. when Iowa River Landing opens. I don't know how often that you guys get to Iowa City, but IRL is our sort of newish building. It's been open since 2012. It's right off of Interstate 80 there in Coralville by the Marriott Hotel. And so that is where general internal medicine is located. And she said, so if I'm going to have to do an evening clinic, I want to do something fun. So what would you think about wanting to start an LGBTQ clinic with me? And I thought, oh my goodness, like this is something that I would sort of dream about doing when I'm old and gray and I have all this political clout that I could kind of leverage. And so at the same time, I'm super excited. We had just heard all of these stories about people, many of them talking about their experiences at the University of Iowa hospitals and clinics, how they felt unwelcomed, how they would go into the emergency room and know that they would be called a name other than what they would like to be called, that they would be misgendered, that they would have pronouns used for them other than the pronouns that they identify with. We heard stories about people calling obstetrics and gynecology who had been on testosterone and had a quite deep voice and saying, I need to have an appointment because I'm having vaginal bleeding. And the person on the other end of the phone line repeatedly telling them, you're calling the wrong place. You don't need to come here for an appointment. I think you have the wrong place. And them saying, no, really, I do need an appointment here. And them saying, no, we're not going to make you an appointment. We heard people calling for an appointment with the Department of Endocrinology, which is the docs that do hormones, so it sort of made sense, and being told, we actually don't take care of people like you. So we heard these stories after stories just about how folks really felt unwelcomed. And we were able to look at sort of larger national data and knowing that the experiences that these patients were having in Iowa City was not unique, and that this was a problem that was being seen over and over and over again. And so while I was super excited, I was also somewhat cautious because the University of Iowa Hospitals and Clinics is a large place, and things do not move quickly by any sense of the word, right? And so I'm thinking, sure, I would love to do this, but I really didn't have an understanding for just the force of will that is Nicole Knisley, and how she was able to make that happen with the gray hairs on her head and the clout that she had. And so for the next 6 to 8 months, we had multiple meetings on a weekly basis, if not more, where we went all the way up from the then President Sally Mason to talking to legal counsel, to the administrators, to our department chairs, to our nursing staff, to the front desk staff and schedulers to get buy-in for this clinic. And we made sure that everyone that was going to potentially touch that patient on a Tuesday night was trained, and so they had gone through safe zone training, and so they really felt comfortable with the language and the terms, some of which I'll talk to you about today. And so when the clinic started, while we had great support from the administration, they also really just said, like, okay, sure, so maybe you could do this, but if your schedule's not filled, will you still see the earaches and the sore throats? Because the evening clinics were always an acute care clinic. And so we should, yeah, sure, of course, we will see anybody. We'll just see how it goes. And so quickly, word of mouth and a couple newspaper articles and a story on Iowa Public Radio, and all of a sudden, we're not seeing sore throats and earaches. We are 6 months booked out right now, both of us. We've added a pediatric endocrinologist to our group, and we've seen over 600 unique patients in those almost 5 years. And people sometimes think, like, of course, because you live in Iowa City. You look under a rock and you're like, oh, there's another one, a gay. Oh, look, behind that bush, I saw a transgender person, right? But to be honest, 80% of the patients that come to see us are not from Johnson County. They are coming and driving from rural Iowa. They are coming from western Iowa. They're coming from Marshalltown. I have folks come from Ames routinely. And these are patients who are coming because they've been told again and again and again by their provider that they don't know how to care for them. And so Dr. Knisley and I would love to work ourselves out of a job. we would love to, and this is what we spend a lot of time doing. I lecture to medical students and residents and faculty and staff, and I would love for those patients to be able to get the care that they need locally. My argument is always that as a family doc, I do tons of things that are a lot harder than managing hormones for trans patients. And while 80% of our patients come from outside of Johnson County, about 80% of our patient population also identifies as transgender or gender nonconforming. So we still have quite a few gay men, lesbian women. I deliver babies, and it's super duper fun when I have a 2-mommy family and we get to talk about that and do that. I take care of kids. I really do love my job. My job is amazing, even though I want to work myself out of it. But I feel like I have the very, very best of what there is in the world. I routinely see kids. So we have a peds endo doc that has started, and she usually sees kids that are 14 and under, and I see kids that are typically 14 and over, and then I'll see, adults and everything like that. But so, I have a pretty biased sample where I get kids that have been brought to see me by parents that are supportive. So I'm sure that for every kid that comes to see me at 15 with parents who are at least supportive enough to bring them in the door, there's 10 of them whose parents are not supportive, right? But the stories that I get to hear and the interaction that I get to see where you're sitting across from a child and their parents who are just saying, I didn't get a manual for this. Like, I took this kid home, I named them, I had these dreams and hopes, and this is the vision that I had, and it has all been turned around, and gosh, I don't know what I'm doing, but I'm trying. And they may try to use this name that this kid wants to be called, and they're going to try to use these pronouns, and I'm going to model that the best that I can, and always it ends up that there's tears, and that those parents say, I just want you to know that I love you so much, that I unconditionally want you to be happy and be who you are. And things can be falling around us in the world, and I can leave my clinic on Tuesday nights and think, you know what, there's some good people in this place, and there's a lot of love in this world. And those are some of the reasons that I really, really love what I do, and that I think caring for transgender people, sort of like delivering babies. Like, people are happy to come to see you. They're happy to be in the hospital. And you really can't say that about a lot of other things in medicine. Disclosures here, nothing financial. I will discuss pharmaceuticals, medical procedures, and devices that are unapproved for use by the FDA, and that's medications and surgeries used to treat gender dysphoria. Our objectives today: understand the distinction between sex and gender. We'll talk about some gender-inclusive terms and definitions, review the diagnostic criteria for a diagnosis of gender dysphoria, and understand the accepted standards regarding treating transgender patients to relieve dysphoria, and also hope that you can assimilate some of this language and the attitudes needed to become affirming for your gender nonconforming patients. So much of what I'm going to talk to you about today are not things that I'm going to hope that you all of a sudden turn on, because Ellen DeGeneres may not walk into your office so you know, oh yeah, I got it. She's a lesbian. I'm going to use these good terms and definitions now, right? Like, I'm going to talk to you about things that I think that you can incorporate for every single one of your patients. Because your gaydar may not be buzzing on your hip to tell you who's actually gay or transgender or whatever that it might be, okay? So we'll start with a case study. So ZW is a 24-year-old sex assigned at birth female, gender identity, genderqueer, with pronouns they, them, and theirs, who's interested in starting testosterone therapy. Past medical history is significant for depression and anxiety and a history of cutting. So a little bit about their gender history. They always identified as a tomboy as a young person, so what we would sort of call gender nonconforming. Had a gender nonconforming presentation. So these are little girls who are super tomboyish and want to play sports and wear baseball caps backwards and nothing but army pants and cargo shorts. And these are little boys who might want to wear dresses and put on their mom's high heels and put on makeup. Doesn't necessarily mean that they're transgender. It means that they're gender nonconforming. They identified as a lesbian in high school. They were bullied in high school. They first came out and identified as trans when they were 22. They desire hormone therapy, maybe some top surgery. Social history: smoke cigarettes, no drug use, moderate alcohol use, sexually active with women, and a lack of support from family of origin, but a supportive family of choice, including trans-identified friends. So we're going to talk a little bit about language here, and one of the things that Dr. Nisley and I did and had the great pleasure of taking part of when we were thinking about setting up our clinic was that we had focus groups of folks in the university community as well as our larger Iowa City area who identified as trans. And we just asked them, like, what are the kind of things that would make you feel safe if you went to the doctor? And we really tried to get their answers. We talked so much about language. So I identify as lesbian, but that doesn't mean I knew anything about trans folks. This was like, all over. I mean, I could still open up, if we could really open it, I could click on Urban Dictionary and feel like I learn all these new terms every day. I mean, I feel like when I talk to my patients, there's always new terms that I'm learning. And one of the things that we had an appreciation for was just how important that language is and how it's something that, as folks who are not transgender, that we often just take for granted. It's our privilege that we don't really have to necessarily worry about some of these more nuanced languages. And so what I used to think of as sex, I now think of as sex assigned at birth. As a family doc, I deliver babies. And there are rare times where those parents don't necessarily want to figure out or to be told what the sex is at the 20-week ultrasound. And so those are some of my most fun things, right? Like, we're going to have a baby born. It's going to be this big surprise. Usually I'm the one who says it. Maybe the other spouse does or something, or their partner who's there with them. But how do I assign a sex at birth? I don't do like a cheek swab and run a karyotype. I don't draw blood and look at hormone levels. I don't get an ultrasound and look to see what their gonads are, right? I just look at the external genitals and I assign a sex at birth. And it's typically male or female. And of course, we could always have little babies who are born with ambiguous genitalia. We could have young children who don't progress through puberty as we would anticipate. We could have women who, in the midst of a workup for infertility, that they are found to be what we now call intersex, or DSD, disorders or differences of sex development. So old term for that, hermaphrodite, and a newer, more acceptable term, intersex. But even if that baby's been born with ambiguous genitalia, by the time that infant leaves the hospital, they have been assigned a sex at birth, and it's typically male or female. And so contrast that then with gender. And for most of us, we would go, let's say, to some place where they still do like a blank paper form or a paper form in general. And if they had a line for sex with just a fill in the blank or a line for gender, fill in the blank, we would think it was just one and the same. But in reality, and what I'm hoping that you leave today with is this understanding that those are really two distinct and different things. And so when we talk about gender, we can break it down to a couple of different terms, one being gender expression. And we all made a decision this morning about our gender expression. Did we wear pants or a skirt? Did we wear makeup or not? Did we wear jewelry or did we not? Did we shave our facial hair or did we leave ourselves, with a beard or a mustache or whatever that might be? These are all ways that we express our gender, our clothing, our mannerisms, our voice. Gender norms are what society expects of us. So for many of the women in the room who are providers, I would bet that most of you have at some point in time been asked or been mistaken to be a nurse, if you weren't already a nurse prior to that. And for many of the men, that's probably never happened to you. So this is just something about what our society and our culture expects of male or female persons. And then we have gender identity, and this isn't what culture and society think about us or impose upon us. It's one's own personal sense of being a gendered being. And so we have two different terms here, and we have two different little molecules that you can harken back to your organic chemistry days, those of you who went through organic chemistry. When I have med students, I often have one of them that collapses. They're just like, don't talk about it. I just got through it. So no one here looks like they're having that experience. I'm glad. So we have sort of two Latin terms, cis and trans means opposite, and cis means the same side. And so instead of saying that we have a transgender man, but we have a natural man or a biologic man or a real man, we can just use the opposite for transgender, and that would be cisgender. So a cisgender person is someone whose sex assigned at birth aligns with their gender identity. So if their sex assigned at birth was female and they identify as a woman, then they would be a cisgender woman. And the converse to that is true for transgender people. We have trans man and trans woman and non-binary. So a little bit about gender identity development. And most of you who have children can attest to this as well, that toddlers, even when they are very young at age 2.5, they can usually look at faces on a page and say if those are boys or girls, or they'll ask about it a lot. It kind of comes into their sort of like area that they'll think about, and they'll often say like, that's a boy, that's a girl. And they'll talk a lot about kind of those body parts that boys and girls have as well. At preschool age, they can usually correctly use masculine and feminine pronouns. They can tell you with great assurity what their own gender is. They can do gender-specific play. So this is when little boys start to stereotypically play with cars and trucks, and little girls start to play with dolls. And there's this belief, though, that maybe one's gender is sort of flexible, like it's not set in concrete. By the time that they enter elementary school at age 5 or 6, they have a more constant or consistent view of gender. So it's not something that can really move. It's really that they have that black and whiteness to their world, that they also move gender into that. Play becomes pretty segregated by sex. The little boys are in a corner playing together. The little girls are in their own corner playing together. And they have this increased construction of gender-conforming rules and roles. So this is when kids start to make fun of those little boys who want to wear pink, or those little girls who wear those baseball caps backwards. And at school age is where maybe then, as they get older, they think some of those rules aren't necessarily so black or white or concrete. So the word trans with an asterisk is written a lot easier than it's said. So trans asterisk doesn't necessarily roll off of the tongue. But what it means when you see it written is that it's essentially just an umbrella term. So if you did a PubMed search and you put a base term in and asterisk after it, you would get all of the results that had that base term in that search query. And so that's what we're really getting at here. And this is someone who has that incongruity between their sex assigned at birth and gender identity. And usually they do not conform to what society expects for someone with that sex assigned at birth in terms of their gender identity or what they personally feel, or their gender expression and how they present themselves to the world. There's the term transsexual, and this is, in its truest sense, a trans person with an overwhelming desire to fully live in their gender identity by doing something medically to transition. And that typically is either medicines or gender-affirming surgery. And what I'll tell you is just to be a little cautious about using this word transsexual. Many, many transgender people feel like it is an overly medical term. They feel like it pathologizes them. Much how I feel about the term homosexual. So when I hear the term homosexual, I think back to how homosexuality was in the DSM-3 up until 1973. So it was a psychiatric illness. When I hear the term homosexual, in my mind, I picture people standing on stumps, giving political speeches, or behind a pulpit, talking about it in really unkind ways. So I identify as a lesbian or gay, but really not as homosexual. There are other people who strongly do identify as homosexual. So I wish that I could tell you exactly what words to use and what words not to use. I'm just going to tell you in my experience and what I think is sort of the safer words to go with. You can use the word transgender, and at today's day and age, it means the exact same thing to most people as transsexual. So I would be a little bit safer about it and use transsexual, or use transgender, as opposed to transsexual. So some specific terms regarding transgender folks. And I think that some people may be more familiar with things like FTM, or female to male, or MTF, or male to female. And I'm with you. It paints a picture in your head. You know where you're starting, you know where you're going, and it's easier to remember. But I would encourage you to try to use instead some words like trans man and trans woman. And the reason is this. It's because when you use something like female to male, that you also have this idea of what that means. There's a starting place and there's an ending place. So the starting place is that you have breasts and a vagina and you look and you act a certain way, and then the ending place is that you no longer have breasts but you have a male chest. You no longer have a vagina but you have a penis, and you look and you act in a certain way. And the implication then is that everybody needs to follow that same path, and that there's not a great appreciation for kind of that journey within it, or the diversity of experience that people in that community have. And when you use something like trans man, it just allows for that breadth of diversity. I have some trans folks who feel like because they have such strong gender dysphoria that they do need hormones and they do need surgery to treat that. And I have other patients who might just want to change their name. They might want to change their pronouns and the way that they dress, and maybe they need a little bit of hormones, if any. And yet that one person is just as transgender as the next person is. Okay? And this transition word that we use is this process of moving from one gender to the other. And some folks may no longer identify as trans after transitioning to the affirmed gender. This comes up quite often when we sort of look at how do we ask this question. And we are in the midst right now. Are you guys on Epic? Epic, great. So super fun, right? Everybody loves Epic. I actually really like Epic. But Epic, along with every other medical record sort of in creation, has not been especially gender inclusive. So in our Epic land, we just have one field and it's called sex. And you can go figure like whatever that means because we really haven't defined it. But typically we use that field to list one's legal sex. But what we know is at the LGBTQ clinic, we have kind of a pilot welcome questionnaire. I don't know if you guys do welcome, so you get like a tablet when you check in and you get to punch in all these things and it like shoots over into the medical record. It's pretty cool. So we have a welcome tab and there's a questionnaire and we ask people what is their sex assigned at birth, and then we also ask them what is their gender, and we give a whole big list. Not as many as Facebook. There's 47 genders on Facebook, but we give like 5, and then an other, and they can write it in. So we'll say man, woman, trans woman, non-binary, other. And I'm always surprised by our trans people don't necessarily pick trans man or trans woman. They often just pick man or woman. So if we only asked one question, if we only asked what's your gender, we would never know that they were trans. And why is this important? Well, for many reasons. One is then we don't know what we need to screen them for. We don't know what body parts that they have. We don't know what surgeries that they may or might have. We don't know if they might be pregnant, okay? One other reason is we think about the lack of research that's been done on trans people. We think, well, we should do something about that. There's no way that you could go back into our record system and actually find out who's transgender because we don't ask. We don't ask these questions. So the best way to ask is asking at least 2 questions. What is your sex assigned at birth? What is your gender? If they don't match, that person's trans. So we've talked really about binary folks. So we have kind of trans men or trans women. We have 2 bathrooms to choose from. There is this kind of binary either or. And then there are folks who identify as non-binary. And so this is when I sometimes lose people and they start to just like their head spins and they're just not really sure that they can wrap their head around it. But these are people who really reject the binary gender. And if we can come to the point where we can think much like sexuality, much like sexual orientation, that maybe there's not just you're either straight or gay, there's nothing in between, but maybe gender is the same way. That there are folks who might fall somewhere along this spectrum, and maybe it's in the middle, and those are the people who really identify as non-binary. Non-binary is an umbrella term. Within that, there are some specific words like third gender or genderqueer, androgynous, gender fluid, things like that, okay? And while these people may not also identify with one of the binary genders, they also may not use the pronouns that align with those. And so they may use pronouns like they, them, or theirs, or ze, or zers, or ne, nim, or nears. And so I do sometimes get some pushback from people saying like, all right, like I got it. I'm gonna call them by their name that they want to be called, but really, like these pronouns, I'm talking to one person, I'm using plural pronouns, my grammar teacher's rolling over in her grave, you know, or I've trained my dragon to say a lot of things, but I don't know that my dragon can pick up Z. But I'll tell you that I was doing a working group once for how our agencies in Iowa City were responding to survivors of sexual assault who are transgender and gender nonconforming. And so we broke into small groups and we kind of answered these questions. We came back to the larger group and presented. And this group had a whiteboard and there was somebody who drew UIHC and they drew barbed wire around it. And they said, this is what people in the trans community feel like going to the University of Iowa hospitals and clinics is like. Because they know that they are not going to be treated well there. They know that it doesn't matter if they come in with a full beard and you know, looking as masculine as can be, that if their record says Michelle, they're going to be called Michelle and they're going to have she, her, hers used for that patient the whole time. And so I think that if all that it takes is that we ask somebody what their pronouns are, and then we importantly use those when we document about them, when we talk about them, that I think that we can do that. That we can go that little bit extra to really honor that person and make them feel like coming and getting health care is not something that they should be afraid of. So these are the kind of things that I'll say, that I have indeed trained my dragon to say. Do you guys use dragon? Nobody knows what Dragon is here. Gosh, it's voice recognition. Dragon's like really, really great, actually. You know, you maybe that's great too. Maybe you can train that. Yeah. Yes, you can train your immodals to say things like Z's, ears, ears. Okay. So Emily's a 37-year-old genderqueer person, sex assigned at birth male. They complain of abdominal pain that has affected them for the past month. Emily states that they have tried Tums without relief of their pain. This is hard. It's pretty hard. It takes some practice. The good thing is that when you're just talking to a patient, you don't pronoun them. When you're talking about them, you pronoun them. So you're off the hook if it's just you and them in the room. If they have a third person, then you're starting to sweat a little bit because you're like, oh my gosh, if that person asks me a question about this person, I'm going to have to use these pronouns. Okay, but you get a little bit of time when you document, think about it, put it in there. My nurses are so good. They say, hey, I just got a phone call from so-and-so. Remind me what their pronouns are because we have open notes. So any phone note, the patient can go into my chart and see. It's so meaningful for them. And with our new Epic, with the new upgrade, we just got onto 2017. They have a whole section on there for gender identity stuff that we're rolling in and hopefully going to be turning on soon. And one of the things is we can ask pronouns. So everybody can know. It doesn't have to be hidden in a note. I'm super excited about it. Jordan is a 24-year-old genderqueer person, sex assigned at birth female. Z complains of abdominal pain that has affected Zier for the past month. Jordan states that Z has tried Tums without relief of Zier's pain. And then finally, we're just going to spend a little bit of time talking about sexuality. And so most folks maybe are more familiar with this as opposed to gender identity. I'll just point out a couple of terms here. So pansexual means that you are attracted to a person. I think that it's sort of like the hipster bisexual in some ways. So it doesn't mean that it's just cisgender men or cisgender women. It can be transgender people. It can be non-binary people. When you go to filter on your Match.com, gender is not one of the things you're going to filter by, okay? Asexual means that you do not have any sexual attraction. Maybe you have this desire to be in a companionship with someone, but sexual activity may not be something that enters into that relationship. And then queer, in its truest sense, could take place of all the letters. So we could just call ourselves the queer clinic because it just means someone who is a sexual or gender minority. The reason that we don't do that is because for some people it still is thought to be a very, very derogatory and hateful term because it was used like that for many, many, many years. So not everyone identifies or would like for you to use that term. The younger crowd has really reclaimed that and used it in a quite positive light, and in many cases, very successfully so. But a little bit of caution, just because you've had this lecture, you want to try it out the next time, and you know somebody's LGBTQ or they identify as that in that community, don't just throw it out there like, so how are things in the queer community? It may fall flat, it may be fine, but listen to the terms that patient uses and then echo those back to them. Questioning just means someone who's questioning, so they don't necessarily know. And then, so that is sort of the identity and orientation. And then we also have behavior. And so sometimes we really focus on behavior because it guides what we do in terms of screening and anticipatory guidance and counseling. And so we have nice acronyms, MSM, men who have sex with men, WSW, women who have sex with women, WSWM, women who have sex with women and men. And then for trans patients, there's just too many moving parts to figure out like 3 or 4 letters. So we need to know what body parts does your patient have, what body parts does their partner have, and how do they put those body parts together so you know what to screen for. And importantly, you need to remember that sexual orientation and gender identity are distinct things. So just because we know what someone's gender identity is, doesn't mean that we know what their sexual orientation is. And the vice versa is also true, right? In sexual orientation, as a family doc, I'm like super duper into holistic, comprehensive care and really feeling like I know the things that make my patients tick. And one of those is that sexual orientation, we kind of often use these indirect variables as a marker for it. So for many of us, we may just sort of think like, well, I know their relationship status. I know that this 45-year-old man that I've seen for a long time, I take care of his wife and his kids, he's married, so of course, he's straight. Of course, his desire is only to have sex with women, just one, his wife, that's it. And that his behavior is in alignment with that. And in reality, I think that if we can get rid of some of those assumptions, and if we can really get to the core of what makes up sexual orientation and ask some of those follow-up questions, that we may learn a lot about our patients, and we may learn that there's some things that we would have missed otherwise. So LGBTQ self-identity matrix, this is just not LGBTQ, this is all of us. What makes up our self-identity in terms of our sexuality and gender are those things. So sex, so our biology, the organs that we have, the chromosomes, our external genitals, our gender, our own internal sense of being a gendered person, and then our sexuality. So these are the terms to avoid, the terms to use. It's my medical student slide. Like, just tell me what to say. Tell me what's on the test. What do I need to know? So we talked a little bit about queer, kind of plus or minus there, plus or minus homosexual, plus or minus transsexual. The term transgendered with an ED, I'm not gay or lesbian, I'm just lesbian. So you can use just transgender for that. Instead of saying things like a real man or a real woman, you could say a cisgender man or a cisgender woman. And again, instead of saying MTF or FTM, try to say trans man or trans woman. And sexual reassignment surgery, some people refer to that as gender affirming surgery or gender confirmation surgery. So some specific things about trans demographics. So there are not any great studies. Again, we talked about how this is a hard number to kind of put our finger on because we don't ask this question often. This is one study that was done in Massachusetts, and it was published in the American Journal of Public Health back in 2012. Wasn't at all about like trans folks. They just asked the question in their demographics. Like, so they called people on the phone and they asked them, "Hey, what sex were you assigned at birth?" And they gave an answer, male or female. And they said, "Okay, what gender do you identify with?" And they said, okay, if those match, these are cisgender people, and if they don't, they're transgender people. So really broad definition, I would say appropriately so. And they found that it was actually a 0.5% prevalence, which is much higher than what a lot of the other studies when they look at the Netherlands and things like that, where they have national health care and they have this national center that trans people go. And so that would be about 1 in 200 people. If you're an average primary care doc, you have about 2,500 patients in your panel. So that'd be that you have 12 transgender patients. This was again done in the whole state of Massachusetts, not just the Boston area. So whether or not that can kind of, be extrapolated to Iowa is unknown, but I think it at least gives us a place to start. So we'll talk some about kind of what these terms mean and how the diagnosis is made. So we have gender identity disorder and gender dysphoria. And gender identity disorder was what the term was in the DSM, so in the Psychiatric Diagnostic Manual, up until very recently in May of 2013, where they changed it to gender dysphoria. And so there was a lot of angst with this term disorder, and people felt like it really was pathologizing. So if people just had a variance from normal, that it made it a pathology, it made it a disorder. It reinforced this binary view of gender, either or, male or female, and that it increased stigma and discrimination against trans folks. So very similar arguments to having homosexuality in the DSM-1 and 2. And so there was this argument, though, that we need a diagnosis somewhere, because if we want insurance companies, and many do, to cover the medications or the labs or the surgeries, we have to give a diagnosis. And so that's the reason to keep it somewhere in there. Maybe not in the DSM, but somewhere. For now, it is still in the DSM. And so there were some of those suggestions. Change the name, lose disorder, put on dysphoria, and that's what was done. So how do we make that diagnosis from the DSM-5 for gender dysphoria? There's 2 criteria. The first one, criteria A, there has to be this incongruence between one's experienced gender and their assigned gender. So they used the term assigned gender here. I would say assigned sex at birth. That is there for 6 months or longer. It's persistent, it's consistent. They didn't just decide this last week after they watched a really cool YouTube video, right? It's been going on for a long time. They need to have 2 of the 6 of these next things. So as you would expect, an incongruence between one's experienced gender and primary or secondary sex characteristics, a desire to be, in fact, rid of those. So I have so many trans men, I've yet to meet one who say that they like their breasts. All of them want to be rid of those breasts, and they want to have a male chest. So a desire for the primary and or secondary sex characteristics of the other gender, a strong desire to be the other gender or to be treated as such, and a conviction that they have typical feelings and reactions of that other gender. And importantly, it has to be met with criteria B, which is there's this distress or impairment in social and occupational functioning. There's increased suffering, distress, or disability. So this is the dysphoria part of it. And they came up with this really great couple sentences, so good that I like to read them aloud. Gender nonconformity is not in itself a mental disorder. The critical element of gender dysphoria is the presence of clinically significant distress associated with the condition. So this is really important, saying transgender people are not inherently pathological, right? There's not a psychiatric illness because you're trans. It's the dysphoria, it's the impairment in that functioning that surrounds that for which we treat those people. And so WPATH is the World Professional Association for Transgender Health. These are the international guidelines that have been around for a long time, since 1979. They are on the 7th version of these that was released in 2011. They're coming up and they've convened the committees to make the 8th version. And this is really sort of what we go by in terms of when we decide to treat someone, what the minimum qualification should be before they get hormones and who should be treating them and those sorts of things. So they provide some guidance regarding the eligibility for hormones and surgeries. And so what they say is that for someone to be able to be treated with hormones or surgery, that they need to have persistent, well-documented gender dysphoria. They have to have the capacity to make a fully informed decision and give consent. They have a whole section in there about adolescents. We're not going to talk about that today. We're just focusing on adults. So they have to be 18 years or older. And if they have some significant medical or mental concerns, that they must be well controlled. So the recommendations for hormones is that 1 mental health evaluation is required. So back in the standard of care version 6, you needed 3 months of therapy or 1 year of real life experience. And so they have really gotten moved away from those big barriers or those big hoops to just saying that you just need 1 mental health evaluation. Some of those reasons is this, trans people are kind of at the lowest rung of the totem pole, right? Like, these are folks who often do not get hired for jobs. They lose their jobs. They get discriminated against routinely in things like housing. If you don't have a job, you often don't have health insurance or you're underinsured. And so to say that these people needed to have 3 months of therapy is a pretty big barrier to overcome. And similarly, asking them to have 1 year of real life experience without any hormones can be potentially dangerous. I've had a number of patients who will tell me, what it's like to try to present and dress and live fully in the gender that they are without having the help medically or surgically. So that mental health evaluation typically takes the form of a meeting with a therapist. They're going to take a gender history. Maybe they're going to encourage some ongoing psychotherapy, but it's not required. And hormones and surgery may be used in any combination to suit the needs of the individual patient. And this again comes back to the fact that there are some folks who need, just a little bit of hormones and don't ever feel like they need surgery. And there's some folks who feel like they need hormones plus surgery to treat their dysphoria. And so it doesn't give this blanket statement like you have to do this, and then they have to do this, and they have to do this. You can have any of those things, and it's okay if people end up in a non-binary state because that's how they identify. Additional recommendations for surgery: mental health evaluation from 2 providers. Continued therapy is again encouraged but not required, and that they need to have been on hormones for 12 continuous months for everything except for chest surgery. So if we're talking about removal of gonads, that they need to have continuous hormones for 1 year, plus they have to have had lived in that affirmed gender during that time. So those are things like phalloplasty, metoidioplasty, which is kind of where you take the clitoris and you make some incisions to the clitoral hood where it's kind of released, and so that clitoris becomes what would essentially be kind of a small phallus, or vaginoplasty. And that need not be present for gonadectomy or kind of removal of the testes or ovaries or chest surgery. So this mental health evaluation, they're going to be talking about their judgment, decision-making, information processing. Can they understand what the risks are, the benefits, why they want to do this? Talk about their gender history. Has it been persistent, insistent? Do they have the financial support and the social support to succeed in this? And then again, they would confirm this diagnosis of gender dysphoria. This is kind of a small slide here, but what our informed consent document looks like. We have a clinical pharmacist who works with us in our clinic on Tuesday nights, and she is kind of the most amazing thing. I don't know, we had a couple pharmacists in here, but my goodness, if I could just carry her in my pocket all day, I would be a better doctor, I tell you that much. So, but one of the things that she does, which is so really great and helpful for us, is that she is the one who takes the time and discusses with that patient the risks and the benefits of these medications, the routes of administration, and which one that they would choose. And then we also have some video links on our website, and those are here, where you can watch the presentation and hear the voiceover talking about the time course of feminizing therapy, the medications that we use, the risks and the benefits. And if Michelle's not there, I put someone in a room and I press play, and then I come back 17 minutes later to answer questions. And it is very time-saving and very informative for the patients. They're on our website. Patients often look at them beforehand or talk with their friends or family and have them go through them as well. So why do we do this? So there have been a number of studies that have looked at the outcomes of gender-affirming treatment. And so what they have found is that using hormones and or surgery to treat people with gender dysphoria has been quite successful. It lowers the rates of anxiety, depression, and stress. It increases their perceived social support and increases health-related quality of life. And so these are just a little bit of sort of some of the studies that have been done that basically say that we have good research behind this. This was a meta-analysis of 28 different studies that showed that with hormones and or surgery that there was improved gender dysphoria, improvements in psychological functioning, comorbidities, lower rates of suicide, which we know is a big issue in this population, higher rates of sexual satisfaction, and again, an overall improvement in quality of life. And there have been many, many medical associations who have come out and said that, in fact, gender-affirming treatment isn't just cosmetic, it's not aesthetic, but it is medically necessary, just like giving someone insulin to treat their diabetes. And those include ones that don't tend to be very left-leaning, like the American Medical Association. The family doctors, public health, psychologists, psychiatrists, pediatricians have said that as well. Back in 2008, which is, now it seems like almost a long time ago, so 9 years ago, was when the AMA said that there was an established body of medical research that demonstrates the effectiveness, medical necessity of mental health care, hormone therapy, and sex reassignment surgery as forms of therapeutic treatment for many people diagnosed with what was then referred to as gender identity disorder. And that they recognize that these treatments can provide a safe and effective treatment, and be it resolved that our AMA support public and private health insurance coverage for treatment of gender identity disorder as recommended by the patient's physician. So this has obviously not happened across the board. We have very good coverage from Medicaid for things like hormones. Medicaid will not cover surgery. If someone is a student at the University of Iowa, or a faculty or a staff at any of our 3 state schools, Iowa, Iowa State, or UNI, right now their health insurance will cover hormones and surgeries. So if they have student health insurance, if they're faculty or staff, they can get those covered. The surgeries as well. They can come to the University of Iowa and they can have top surgery in terms of male chest reconstruction or breast augmentation. We don't have anyone doing vaginoplasty, but we have a urologist that's doing orchiectomy. We have our gynecologists that are doing hysterectomies. Those would be covered by their insurance. So just a little bit to close, primary care for some transgender folks. So just some things to think about. Breast cancer screening with mammography. If you have a transgender woman, so again, we're talking about sex assigned at birth, male, gender identity, woman. So she will likely have been on estrogen. If she's over the age of 50 and she has additional risk factors, that she's been on estrogen or progestins for more than 5 years, if she has a positive family history of breast cancer, or if her BMI is over 35, we recommend to start screening her with a mammogram. Prostate cancer screening, so trans women, even if they have had bottom surgery, so even if they have a removal of their penis and the creation of a vagina, they don't do anything with the prostate. Okay, so the prostate's still going to be there. So PSA testing is sort of, kind of a question mark and shake your head. Who knows what to really do with that in general? But for these trans women who are on androgen blockers, that PSA test is difficult to interpret because it's usually low, and it may be falsely low. And if you just rely on the PSA test and think that you're all good, and if you're going to actually look at that, then you may be fooled. So you can consider it, but you need to multiply it by 1.5 or 2, interpret it with caution. Usually I perform a digital rectal exam just to evaluate the prostate on all of my trans women. And you do not need to do a pap test in a neovagina. So in a newly created vagina, no reason to do a pap test. They don't have a cervix. Transgender men, so sex assigned at birth female, gender identity man. So what about breast cancer screening in this population? So if they have had prior male chest reconstruction, where they've had removal of their breast tissue, annually you can just do a chest wall exam and an axillary exam as well, but mammograms are not needed. So if they've had breast reduction only, but there is still some breast tissue left, or no history of ever having top surgery, then you would do clinical exams and mammograms per your usual guidelines that you follow for cisgender women. Cervical cancer screening for trans men is something that is hard to do. Who likes to have a pap test? Like, people don't like line up, like, give me one of those, that's so fun. And trans guys especially think that it's kind of terrible. So we're talking about kind of a body part that they may not even use a lot sexually because they don't really identify with it. And now we're gonna talk to them about like the need to kind of do this pap test. And they're on testosterone, so they've had vaginal atrophy, and maybe they don't have penetrative sex. So there's many reasons why trans guys don't like to do pap tests, but it's still really important. So cervical cancer screening as per guidelines for assigned sex at birth females. So, every 3 or 5 years, depending on their age and the results. It's helpful. Your pathologist would appreciate it probably if you told him or her in the comments that this patient is on testosterone, because again, it will cause some atrophy and it can cause things to just look a little bit different in terms of cervical cells. Endometrial cancer evaluation. We think about trans guys kind of like we would think about postmenopausal women. So once they're on testosterone for 3 or 6 months, they stop having a period. And so in a postmenopausal woman, if she all of a sudden has some, postmenopausal bleeding, we want to evaluate that, make sure it's not uterine cancer. Same thing in a trans guy. So again, he's not going to be super excited about a transvaginal ultrasound or an endometrial biopsy, but really impress upon him the need to know those things if he is having bleeding. Our OB-GYN department is really, really good about doing some of these tests under sedation if people are very anxious. And so they do a nice service for our patients there. You can consider a hysterectomy if they're more than 40. They've looked at some studies like, are you at increased risk for things like ovarian or uterine cancer if you're on testosterone? There hasn't been anything that can be said with any, that there's nothing definite that says that there is this increased risk. So hysterectomy is just something that you could consider, but not necessarily medically necessary to prevent cancer. So talking with trans patients, ask about their preferred name and pronoun, honor that choice of name and pronoun, use it. So use pronouns that are consistent with presentation. I often say to my students, if a reasonable person might surmise that this patient that you go in and see has a gender presentation that is opposite than what you're staring at on the medical record, then just ask them what name they'd like to be called and what pronouns. And if it doesn't come up and if you don't have a chance, and if you're kind of reporting to someone else, then I would probably use those pronouns that are consistent with their presentation. Everyone will make a mistake. It happens. My nurse, and right now I have very little clinical time. The only real patients that I see are LGBTQ. So I see trans patients, I saw 15 in my afternoon clinic yesterday, and 13 of them were transgender. So my nurse works with them all the time, and today she called a trans guy she, and I went into the room and this trans guy's wife said, your nurse is really, really sweet, but she did call him she. Can you let her know? Mistakes happen. They happen to all of us. So you just make a mistake, you own up to it. Don't act like it probably happens to the patient all the time and they won't care. They do care. Tell them that you're sorry. Use the right one the next time. So back to our patient. Mental health evaluation needs to be completed. Gender dysphoria is present for 2 years. They don't identify as a woman. They identify as genderqueer. They would like facial hair, masculine body type, a deeper voice. They're uncomfortable with their breasts. Importantly, they have the capacity to give informed consent. Depression and anxiety worsened by symptoms related to gender dysphoria, though well controlled on medication. They need baseline labs and they're ready to start on T. And they're able to have male chest reconstruction at any time. And importantly, they need cervical pap testing, so don't forget. Here's just some resources. So Trans 101 is a sort of great place to go and learn about terms and definitions. The Center of Excellence for Transgender Health is from UCSF in San Francisco. This is a great one. I mean, it's like, if you want to know what to do in your primary care doc, they have the primary care protocols for how to treat trans patients. Do you guys use UpToDate here? UpToDate, you can just search transgender and you can learn how to do something on UpToDate as well. So this is not something that's a big secret in how we do it. And then WPATH, like I mentioned. So take-home points, each person gets to self-identify their gender identity. Trans people are diverse, and their sex assigned at birth is not congruent with that gender identity or expression. Sexual orientation is completely separate, And gender nonconformity is not a mental disorder. If it's associated with dysphoria, we have medical and surgical treatments that are helpful and deemed medically necessary. I'm going to open it up for questions now. We have 6 minutes left. So does anybody have any questions? Yes. Yes. Yep, so great question. So the question was, what do I do with an adolescent who comes into my office and is questioning their gender? So we have a pediatric endocrinologist who has just started with us, well, not just, it's probably been 6 or 9 months now, and she comes to the LGBTQ clinic once per month. We were previously just sending patients to her clinic during the regular week. And she was getting so many trans kids that she decided just to come over and hang with us for one Tuesday night. So what the guidelines talk about is at Tanner stage 2. And so what we know is that there are some of these gender nonconforming kids. Many, many, many of them, probably most of them, these little tiny tomboys or these little boys who want to wear their mom's dresses, those gender nonconforming kids, there's a lot of them. The majority of them are going to grow up and be lesbian, gay, or bisexual. Okay? A minority of those kids have gender nonconforming behavior, but they also have gender discordance. This is that little tomboy who doesn't just say, like, I want to grow up and be in the army just like my brother. She says, I'm a boy just like my brother. You know, I don't want to do things that boys do. I am a boy. And so those kids, we still think that when they start to go through puberty, when they get into Tanner stage 2, maybe some of those kids, some things are just going to make sense, and they're going to end up where their gender identity aligns with their sex assigned at birth, and they will probably grow up and identify as lesbian, gay, or bisexual. But some of those kids, when they start to go through puberty and at Tanner stage 2, all of a sudden things get a lot worse. Their body is betraying itself, right? So this little tomboy all of a sudden has a period and she starts to develop breasts, and really these are things that she does not want to happen, and things get worse. The dysphoria that is there really takes hold. And so at Tanner stage 2, we can do something called puberty blocking agents or a GnRH agonist, and that's what our pediatric endocrinologist does. And it's just a pause button. So you just pause puberty so nothing happens, and if you unpause it, then all of a sudden puberty would progress as it naturally would. So around the age of 16 is when you can start cross-sex hormones. So parents have to give consent, the child has to understand and give assent, and you can do that puberty blocking agent at Tanner stage 2, and then cross-sex hormones around the age of 16. And if all of a sudden people think, you know what, like I thought I was trans, but actually I'm not, then you just take Lupron away and they go through puberty as they would have otherwise. Yeah. What other questions? Yeah.
And they are on stable doses of testosterone, and everything's been the same for them for several years, and it seems like it's hard for them to get in with you. Would you guys find it appropriate if I just took over that and then called you if I needed help, or would that be I mean, I'm not an expert, but I feel like, well, I'm willing to learn. If you're willing to bear with me, then you can just stay here, and it's really cost prohibitive to drive all the way over there. And
you got it. So the question was about co-managing patients who have been seen in our clinic or somewhere else who are on kind of stable doses of hormones. For sure, we would love to co-manage with anybody and check out up to date, check out what these guidelines are. The big things is just checking a testosterone level and an estradiol, and hoping and trying to shoot for them being in the normal male range. So, if you have a young man, we probably want his T level somewhere around 300 to 600. That'd be great, okay? We want his estradiol somewhere under 40, just like anybody else that would be his age if they were a cis man. We're looking at lipids, hemoglobin A1C, and H&H, because you can have, some elevations of that, erythropoiesis with testosterone, just to make sure that everything looks good. But it's pretty darn easy once they're on a stable dose, so, yep. Yep, so that's a great question too about sleep apnea when people are on T. Yeah, so just like in cis men, where we've seen that sometimes there are higher rates of things like sleep apnea, I would do the same kind of screening questions. Are they sleeping okay, morning headaches, do they have any snoring, are they waking up to go to the bathroom in the middle of the night, look at their BMI, if you're concerned, get a sleep study. Yep. Exactly. Check out those primary care protocols from UCSF. They're great. Any other questions? Very good. Thank you so much for having me.